Now, the limitation of VA-ECMO in STEMI is like possibility of LV distension, potential high risk for bleeding, and risk of vascular injury. But Euroshock trial, there is non-significant reduction in 30-day mortality and even 1-year mortality with standard therapy plus ECMO than standard therapy only. The trial was underpowered actually, but there is definite improvement. And to compare the different types of MCS nowadays available, IABP has minimal ability to affect ventricular performances, and it depends on intrinsic ventricular performances to provide maximum benefit. ECMO, tremendous total body circulatory support, but does not affect ventricular performance drastically. Impella, good blood pressure support, directly unload LV. So Impella may be an answer in future, but recently a meta-analysis reported the result of 4 ICTs, including only 148 patients comparing percutaneous MCS versus IABP. MCS use did not show any difference in 30-day mortality. Now came PROTECT 2 trial. It has clearly shown benefit over IABP. Impella has clear benefit in 30-day major adverse event reduction, 90-day major adverse event reduction when compared to IABP. After that, USPELA or ASPELA registry comprising of 154 patients, they actually told about early initiation of hemodynamic support prior to PCI with Impella 2.5 is associated with more complete revascularization. What we are discussing in previous talk, that more complete revascularization can be done with this and improved survival in the setting of refractory cardiogenic shock complicating an MI. This is the outcome, and this is the different comparison between the different MCSs. Now, the last part of this discussion is RVMI, complicating with cardiogenic shock. Pulmonary artery pulsatility index is the indicator, hemodynamic indicator of choice for RV failure in inferior wall MI as well as post-LVAD. Shock trial showed RV dominant cardiogenic shock had similar mortality as LV dominant shock. Significant higher in-hospital mortality when RV is involved. The options of these RVMI situations are like surgical RVAD, ECMO, atrial septostomy, Impella RP, tandem heart PROTECT Duo cannula, and Recover Right trial showed Impella RP was safe, easy to deploy, and reliably resulted immediate hemodynamic benefit in life-threatening RV failure. So these are the situations where RV failure and LV failure are, this is a spectrum, the MCSU spectrum. The take-home messages are like that. Early decision-making regarding need of MCS is important. Not to hesitate in putting pulmonary artery catheter when required. Good care of access site is required. Individualize during selection of MCS according to experience of use, follow-up knowledge, hemodynamic data, revascularization plan, and cost effectiveness. Proper weaning of MCS, the timing and techniques are very important. Thank you for your patient hearing.